Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
Leptomeningeal disease in EGFR-mutated lung cancer. Can we finally define a standard treatment? This JCO podcast provides observations and commentary on the JCO article Osimertinib in patients with epidermal growth factor receptor mutation-positive non-small cell lung cancer and leptomeningeal metastases, the Bloom study by Young et al. My name is Jürgen Wolf, and I'm the Medical Director of the Center for Integrated Oncology at the University Hospital of Cologne in Germany. I'm a medical oncologist with expertise in personalized lung cancer care. About 10% of patients with advanced EGFR-mutated lung cancer suffer from leptomeningeal disease. While this disease manifestation in non-small cell lung cancer is generally associated with a particularly poor prognosis, with survival times of only a few months, the question arises whether treatment with specific tyrosine kinase inhibitors might enable a better disease control. Most studies evaluating the efficacy of first and second generation EGFR TKIs in leptomeningeal disease were retrospective and difficult to interpret, given the heterogeneity of the disease as well as of the preceding treatment procedures. Small prospective studies with patient numbers below 20 tested standard dose erlotinib or afatinib, as well as high dose pulsatile EGFR TKI treatment, and reported disappointing results with survival times of around 4 months only. The third generation EGFR TKI osimertinib initially was approved for T790M positive failure of first and second generation EGFR TKIs, and is now commonly regarded as first-line standard treatment for EGFR-mutated lung cancer based on a superior progression-free survival, overall survival, and toxicity profile. In studies with primates and healthy volunteers, osimertinib has been shown to exert a higher blood-brain barrier permeability and a higher brain exposure compared with other TKIs. In the AURA clinical development program for osimertinib, 22 patients with T790M positive relapse after EGFR TKI treatment and leptomeningeal disease were retrospectively identified, and an impressive median overall survival of 18.8 months was reported. A small prospective Japanese trial evaluated osimertinib in 13 patients with T790M positive leptomeningeal disease, which, however, could be confirmed only in 5 patients. Responses were seen in some patients, and the median progression-free survival for all patients was reported with 7.2 months. The Bloom study Part B, which is discussed in this podcast, is a multicenter phase 1 study evaluating osimertinib in EGFR-mutated lung cancer patients with leptomeningeal metastases and failure of previous EGFR TKI treatment. Study objectives were the assessment of clinical parameters like response, overall survival, neurological status, and safety, but also pharmacokinetics in blood and cerebrospinal fluid. Main inclusion criteria included confirmed diagnosis of EGFR exon 19 deletion or L858R mutation, and confirmation of leptomeningeal disease by positive cytology of cerebrospinal fluid and at least one leptomeningeal site accessible by MRI. There were 2 sequential cohorts, one unselected for the T790M mutation and with stable non-CNS disease at enrollment, and one for T790M positive patients without the requirement for stable non-CNS disease. Osimertinib dose was 160 mg once daily, which is twice the approved dose. Besides investigator-based response assessment according to RECIST, leptomeningeal disease was also assessed by a neuroradiological blinded central review according to the RANO-LM working group criteria, which integrates clinical examination, cerebrospinal fluid cytology, and neurexis MRI. 41 patients from South Korea and Taiwan were included, 20 in the unselected and 21 in the T790M positive cohort. About 70% of the patients had coexisting brain mets and about 50% prior radiotherapy. For 4 patients, no response data from the independent review were available. The confirmed overall response rate for leptomeningeal disease was impressive at 62%, as assessed by blinded independent review, and nearly identical between both cohorts. By comparison, the overall response rate was only 27% by investigator assessment, which in turn revealed a higher stable disease rate. Prior brain radiotherapy had no influence on efficacy. Median duration of response was comparable between blinded independent review and investigator, with 15.2 and 18.9 months respectively. In about 1/3 of the evaluable patients, confirmed CSF clearance could be observed. PK analysis indicated that plasma concentration of osimertinib and its active metabolites reached steady state by day 15. The ratio for osimertinib exposure in cerebrospinal fluid versus plasma was around 16%. Surprisingly, only half of the patients had an abnormal neurological baseline assessment, most of them with mild symptoms. Symptom stabilization occurred in 54% during treatment. Only 5% showed regression of neurological functions. Overall, median progression-free survival as assessed by the investigators was 8.6 months and median overall survival 11 months. Progression-free survival and overall survival differed markedly between both cohorts. For instance, overall survival was 16.6 months in the unselected and 8.1 months in the selected group. Possibly, the requirement for stable non-CNS disease in the unselected group was partly responsible for the better survival outcome in this subset. However, this has to be interpreted cautiously in view of small patient numbers and large confidence intervals. Osimertinib 160 mg was well tolerated in the majority of patients with a known osimertinib side effect profile. However, 24% of the patients suffered from adverse events grade 3 or more, possibly related to osimertinib according to the investigator's assessment. Dose reduction had to be performed in 12% and discontinuation of treatment in 22% of the patients due to adverse events. 17% of the patients had fatal events that did not appear to be causally related to osimertinib. What can we learn from this study? This is the largest prospective study so far in this setting, and osimertinib clearly shows clinical efficacy. The study methodology was sound, with response assessment by blinded independent review and based on RECIST criteria as well as on the RANO criteria established in particular for leptomeningeal disease. The overall response rate of leptomeningeal disease of around 60% and the duration of response of around 15 months is clinically relevant, in particular as it is correlated with neurological improvement or at least stabilization in most patients. Also, the toxicity of the treatment is substantially higher than reported in osimertinib trials so far. It is manageable, and the risk-benefit ratio appears to be favorable. What are the limitations of the study? Patient numbers are small, and the patients are heterogeneous with respect to several important factors, such as pretreatment whole brain radiotherapy, occurrence of simultaneous CNS metastases, and neurological symptoms. Thus, absolute values for efficacy have to be interpreted cautiously, and comparison with already published trials remains difficult. Also, unfortunately, in view of the toxicity, the question remains open whether the 160 mg dose, which is not approved, is actually necessary. Finally, since osimertinib increasingly becomes a first-line treatment standard in EGFR receptor-mutated lung cancer, the number of patients with failure of first or second generation EGFR receptor TKI treatment will decrease. Despite these limitations, the trial provides the most convincing data so far in this special patient population and, in my opinion, defines an important new option to consider for patients with EGFR receptor-mutated lung cancer and leptomeningeal disease after failure of previous EGFR receptor TKI treatment. This concludes this JCO podcast. Thank you for listening.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.